So uh, when we are analyzing the heart to reach the particular diagnosis, we need to construct the heart in a 3D model in our brain with the help of ultrasound. And when we are constructing the heart, what we need to do is we have to go step by approach, like as if we are constructing the house. First, the ground floor, then the second floor, then the third floor. First, we need to identify the atrias, the ventricles, the AV connections, then the great vessels. But if we directly jump to construct the third floor, what is going to happen? We will not be able to reach the perfect diagnosis. So coming to the features that we need to know about the various anatomy is what we need to know is the anatomical landmarks. The cardiac chamber is largely defined by the anatomical landmarks on its surfaces, and identifying these anatomical landmarks will help us reach the diagnosis. So coming to the right atrium, the morphological right atrium, I have used morphological because what are the characteristic features which will define that this particular chamber is the right atrium? The first part is the Eustachian valve. The Eustachian valve is the integral part of the right atrium. The chamber which has the Eustachian valve is defined by the right atrium. It is an embryological remnant which diverts the inferior vena cava blood into the left atrium, working as a valve. So these fibrillary structures that we are seeing over here is the Eustachian valve, which is attached just at the insertion of the inferior vena cava. And the another structure we need to know is the limbus of the fossa ovalis. When the septum primum and the septum secundum unites to form the interatrial septum, the dimple that is formed where the secundum and the primum unites is the limbus of the fossa ovalis. And this limbus of the fossa ovalis is facing the right atrium. Coming to the inferior vena cava drainage, the chamber to which the IVC drains is definitely the right atrium. And you have a right atrial appendage. The right atrial appendage has a characteristic shape of a Snoopy's nose, where the base is broader than the tip. What we can see over here is the right atrial appendage, which is made up of pectinate muscles, which is coarse. And what we can see over the base is broader than the tip. Then we will compare it with the left atrial appendage also. And the another structure which opens into the right atrium or which defines the right atrium is the coronary sinus. Coronary sinus is basically the coronary arteries, which ultimately drains the drainage of the coronary artery. What we can see over here is the four chamber view, and we go most posterior part. In the posterior left AV groove, the coronary sinus opens into the chamber is the right atrium. Coronary sinus can never open into the left atrium. When it's open to the left atrium, it is a different entity that we will learn later. In this particular view, the coronary sinus is dilated because the superior vena cava, the left superior vena cava also opens in it. And lastly, the hepatic vein. The hepatic vein will always open into the right atrium. So hence, the morphological right atrium is defined by presence of Eustachian valve, the limbus of the fossa ovalis, the IVC drainage, the coronary sinus drainage, the hepatic veins drainage. Coming to the left atrium, the morphological left atrium is defined by the flap of the fossa ovalis. This is the dimple and this is the flap. The flap is always facing towards the left atrium, and the dimple or the limbus of the fossa ovalis is always facing to the right atrium. The side to which the flap of the fossa ovalis faces is the left atrium. And of course, the pulmonary veins. When three or more pulmonary veins are draining in a particular chamber, that chamber is defined as left atrium. Now coming to the left atrial appendage, what we can see over here is the Snoopy's ear type of left atrial appendage. What we can see over here, the base is narrower than the body. What we can see here, the base, this is the left atrial appendage. When you have a broader base, it is a right atrial appendage. When you have a narrow base with a broader body, here the four-chamber view is also showing the left atrial appendage. This is the short axis view showing the left atrial appendage. The coronary artery adjacent to the left atrial appendage is the left anterior descending coronary artery, or the LAD. This is additional information. So coming to the right ventricle, how do you define a right ventricle? The right ventricle is defined by moderator band and the tricuspid leaflet attachment. What we can see over here is the interventricular septum, and there is an additional structure crossing the apex of the right-sided ventricle. Because you have the tricuspid valve septal insertion attaching to the interventricular septum, we can see this insertion of the tricuspid valve on the interventricular septum. And you can also see that there is an additional band which is crossing the apex. That is the moderator band. The presence of moderator band and the septal attachment of the tricuspid leaflet will define that this ventricle is the right ventricle. Now coming to the left ventricle, what we can see over here is that on the interventricular septum, it is smooth and there is no attachment of the tricuspid leaflet chordae onto the interventricular septum. So there is no attachment on the interventricular septum. It is smooth. Hence, it defines that this ventricle is morphologically a left ventricle. However, we have characteristic features of the valves, the tricuspid valve and the mitral valve. The AV valves, now coming to the AV connection. What we can see over here is there are two AV valves, the right-sided AV valve and the left-sided AV valve. So which valve is a tricuspid valve and which valve is a mitral valve? The valve which is more closer to the apex is the tricuspid valve. What we can see, these both valves are not at the same level. The septal leaflet is connected here, and the mitral valve, there is a leaflet which is connected farther from the apex. So the valve which is more closer to the apex is the tricuspid valve. It has three leaflets and also has the insertion on the interventricular septum. In case of mitral valve, the valve is far from the apex. At the same time, it has two insertions. It has insertion on the papillary muscle and there is no insertion on the interventricular septum. The mitral valve has a characteristic fish mouth bicuspid type of appearance in short axis. What we can see over here, the fish mouth appearance of a bicuspid mitral valve. But you have an unusual scenario where you are not able to diagnose whether this ventricle is a right ventricle or a left ventricle. What we see in some cases like common AV valves or a complex heart, where the VSD is so big that it's difficult to define the type of the ventricle. What we call is the indeterminate variety of the ventricle. Now, after learning the various characteristics of the various structures, we need to know the location or the position of these structures. So for understanding the position of the atria, the term coined is the atrial situs. How is the atria position? The atria situs is termed solitus when it is a normal connection, where the right atrium is on the right side and the left atrium is on the left side. But in case of inversus, when the whole body is inverted, the right atrium will be on the left side and the left atrium will be on the right side. As we can see over here, the inferior vena cava opens into the right atrium, and this right atrium is on the right side, and this is the left atrium where the pulmonary veins are opening. So right atrium is to the right and the left atrium is to the left, and hence it is atrial situs solidus. But in this particular case, the IVC is opening into the atria, which is onto the left side. So this left-sided atria is morphologically right atrium. Hence, this right atrium is on the left side. So it is called atrial situs inversus. Sometimes it is difficult to define because of various abnormal connections like right isomerism and left isomerism. We cannot define that right atrium and this is left atrium. Two pulmonary veins opening on the either side. The superior vena cava is not opening. The IVC is interrupted. So it is difficult to define the atria. So it is known as ambiguous. Ambiguous type means you cannot define. And the examples being the right isomerism where both the atria wants to become like morphological right atrium. And in left isomerism condition, both atria wants to become the left atrium. Now coming to the bulboventricular looping. So what is bulboventricular looping? Bulboventricular looping is basically the embryological event in the formation of the ventricles. When there is a bulboventricular looping event happening in the embryology of the heart, when the heart is formed, this bulboventricular looping leads to formation of the right ventricle and the left ventricles. And this bulboventricular looping can be of two types. That is the right-sided looping and the left-sided looping. The D looping is called the right looping and the L looping is called the left looping. Normally, there is a D looping of the ventricles. So when D looping happens, the morphological right ventricle will sit on the right side and the morphological left ventricle will sit on the left side. But if left looping occurs or L looping occurs, there will be inversion. The right ventricle will be on the left side and the left ventricle will be on the right side. As we can see over here, this is a tricuspid valve, the interventricular septum. There is no attachment on the left side. So this is the left ventricle and this is a tricuspid valve and there is attachment on the interventricular septum. So this is right ventricle. So right ventricle on the right side and the left ventricle on the left side. So it is a D loop ventricle. But in this particular case, the tricuspid valve is on the left side and the bicuspid valve is on the right side and the interventricular septum is having no attachment on this ventricle. So this is morphologically left ventricle and this is morphologically right ventricle. So morphological right ventricle on left side means it is L looping of the bulboventricle. These two things, the bulboventricular looping is regardless of the atrial situs. It is not necessary that if atrial situs solitary, it has to be D looping. It can be L looping also, and it can be D looping also. And similarly for atrial situs inversus, it can be D looping or it can be L looping. But the common thing is the AV valve. The AV valve or the atrioventricular valve always goes with the ventricles. Like a tricuspid valve will always go with the right ventricle and the mitral valve will always go with the left ventricle. It cannot happen that tricuspid valve is sitting on the left ventricle and mitral valve is sitting on the right ventricle. It will never happen. And another important point is the convexity of the aorta points to morphological right ventricle. We'll go to the previous slide. What we can see over here is this is the right ventricle and this is the aorta. And the convexity of the aorta, this is the convexity of the aorta is towards the morphological right ventricle. So in any case, the convexity of the aorta will face morphological right ventricle. So when you are confused whether this ventricle is right ventricle or left ventricle, if you are able to define the convexity, the ventricle facing the convexity will be the morphological right ventricle. So in this particular case, this valve is having a insertion which is slightly at the lower level and this insertion is higher, far from the apex. So this left-sided AV valve is actually the tricuspid valve and hence this regurgitation is tricuspid regurgitation and not the mitral regurgitation. Now the role of sterility is very important to define the flow pattern of the right ventricle. So this hand is a right hand and this hand is the left hand. So when you have a normal heart, that is situs solitus with a D loop ventricle, the morphological right ventricle is a pictorial depiction of the right hand, where the thumb becomes the tricuspid valve, the palm becomes the interventricular septum, the fingers become the right ventricular outflow, the wrist becomes the apex, and the back of the hand becomes the free wall. So this is the inflow of the right ventricle, this is the body of the right ventricle, and this is the outflow of the right ventricle. So this is the morphological right ventricle will behave like a right hand in case of situs solitus and D loop, normal heart. But in case of situs inversus, the morphological right ventricle will behave exactly mirror image, opposite, that is our left hand. So the thumb continues to be the tricuspid valve, and the finger continues to be the RV outflow, and this is the inflow, this is the body, and the outflow. So now coming to the placement of the cardiac apex. And the placement of the cardiac apex has to do with the bulboventricular looping. So how does this happen? In patients with atrioventricular concordance, if you have a D loop, then the apex is towards the left hemithorax. What we call is the cardiac apex is to the opposite of the bulboventricular looping. So when you have a right ventricular looping or a D looping, the apex is towards the left. Means in normal case, what is the looping? Is a D looping. So when the looping is D looping or the right looping of the ventricle, the apex will be towards the left. But in case of situs inversus, there will be L looping, and hence the apex will be towards the right. But in case of AV discordance, the intraventricular septum is malposed. It is oriented sagittally, and hence it will lead to mesocardia. There will be mesocardia in case of atrioventricular discordance. So in major cases of corrected TGA, we see mesocardia. There are a few abnormalities, like you have a superior inferior ventricle when the interventricular septum is horizontal, and we have one more entity called criss-cross connection. So we will see what is criss-cross connection. Normally, the right atrium opens into the right ventricle, the left atrium opens into the left ventricle, such that both are in topographic alignment with each other. But when the right atrium opens into the right ventricle, which is on left side, and the left atrium opens into the left ventricle, which is on right side, then it is called a criss-cross connection. Now, after learning the looping, we come to ventricular-arterial connections or the great artery connections. The ventricular-arterial connection normally are defined by the right ventricle will open into the pulmonary artery, and the left ventricle will open into the aorta. When these connections happen, it is known as atrioventricular concordance. But when right ventricle give rise to aorta and the left ventricle give rise to pulmonary artery, it is known as ventricular-arterial discordance. It is not necessary that the ventricular-arterial connections have the same spatial interrelationship. Means the position of the aorta and the pulmonary artery has nothing to do with the ventricular-arterial connection. So how do you define that the particular vessel is aorta and the particular vessel is the pulmonary artery? So if there is a coronary artery arising from a particular vessel, it is aorta. What we can see over here, this is a structure, and we can see the coronary artery arising from this particular structure. So this structure is an aortic valve, and this particular structure has a branching pattern. The right and the left branching cannot happen with the aorta. So this is pulmonary artery. But there are few limitations to this rule also. For example, Alcapa, where the anomalous origin of left coronary artery from pulmonary artery. So when you have a coronary artery arising from the pulmonary artery, so this vessel is actually the pulmonary artery, though the coronary artery is seen arising from the particular vessel. And hemitruncus. Hemitruncus is when the either of the pulmonary artery is arising from the aorta. In this particular case, what we can see is the main pulmonary artery is continuous as left pulmonary artery, and this right pulmonary artery is arising from the aorta. So now coming to the relationship of the great vessels. We have four types of relationship of the great vessels: the normally related great vessels, the I malpose great vessels, the D malpose great vessels, and the L malpose great vessels. In normally related great vessels, what we can see is the aorta, where aorta is posterior and to the right of the pulmonary artery. So how do you define aorta? Aorta is defined by the presence of coronary artery arising from it, and the pulmonary artery is defined by the branching pattern. So this vessel is the branching pattern, is the pulmonary artery, and this vessel is the aorta. So when aorta is posterior and to the right, it is known as normally related great vessels. When aorta is posterior and to the left, this is the pulmonary artery, and this is the aorta, which is posterior and to the left, and this is pulmonary artery, which is onto the right. So it is known as I malpose, what we see in situs inversus. In case of D malpose, the aorta becomes anterior and to the right. So this vessel is showing a coronary artery arising from the anterior vessel, and the posterior vessel is a branching one. Hence, the pulmonary artery is posterior and the aorta is anterior. But aorta is anterior and to the right, and hence it is D malpose, what we see commonly in transposition of great arteries. In this particular case, we see the aorta is anterior but to left of the pulmonary artery. So this is L malpose great vessels, which is commonly seen in corrected transposition. There are various abnormal connections also, like DORV, DOLV, double outlet right ventricle, double outlet left ventricle, single outlet, could be in the form of truncus, aortic atresia, pulmonary atresia. Now coming to the rule of 50%, whether to qualify this ventricle as ventricle or not. So when any cardiac chamber receives 50% or more of the inlet or the valve, is defined as ventricle. This ventricle may not have an outlet. So presence of outlet is not necessary to define the ventricle. If 50% or more of the great artery arises from above the chamber, then the great artery is defined as connected to that chamber. But if the chamber is receiving less than 50% of the inlet, then we don't call that ventricle as ventricle, but it is known as a rudimentary chamber. And if this rudimentary chamber has more than 50% of the outlet vessel, then it is known as outlet chamber. And if this rudimentary chamber does not have an adequate outlet or less than 50% of the adequate outlet, then it is known as trabecular pouch. In this particular picture, what we can see over here is this is a ventricle which is receiving mitral valve flow and also the tricuspid valve flow, but this right-sided ventricle is receiving less than 50% of the inflow. Hence, this particular, the right-sided ventricle cannot be qualified as ventricle, but has to be qualified as rudimentary chamber. But this rudimentary chamber is having more than 50% of the outflow, and hence this rudimentary chamber is qualified as outlet chamber. You have outlet, so this is known as a rudimentary chamber and outlet chamber. But if this would have not happened, there is no outlet, then it would be qualified as trabecular pouch. These type of ventricles are seen in more complex heart disease. So now coming to the abdominal situs. Abdominal situs is usually concordant with the atrial situs. So how are you going to define abdominal situs? Abdominal situs is defined by four structures: liver, stomach gas, infra vena cava and aorta. If the liver is on right side and the IVC is on right side and the stomach gas and the aorta onto the left side of the spine, then it is known as abdominal situs solidus, and it coincides with atrial situs solidus. If the stomach bubble is on right side and the aorta is on right side and IVC and liver is on left side, it is known as abdominal situs inversus, which coincide with the atrial situs inversus. Similarly, when it is difficult to define on which side the either structure is, in this particular case, the liver is in the center, the stomach bubble is in the center, and you have the IVC and the aorta, both the structures on one side. Then it is known as situs ambiguous. So now coming to various isomerism, right-sided isomerism. What is right isomerism? When both the parts of the body wants to become like right side. So nobody wants pulmonary veins. Both of them want superior vena cava. So we will have bilateral SVCs. We will have TAPVCs in patients with right isomerism. In patients with left isomerism, both the side wants to become like the left side. So nobody wants superior vena cava. Both of them, nobody wants IVC, and both of them wants pulmonary veins. So two veins will go onto the right sided atrium, the two veins will go onto the left sided atrium. So now coming to the last topic of the today's evening session, that is dextrocardia. The dextrocardia are of three types. This image will help us understand. This is a normal levocardia heart where the apex is facing towards the left and the heart is also in the left hemithorax. When this whole structure just slides into the right hemithorax with the apex still facing towards the left, you will see a dextrocardia with apex facing towards the left, and this is known as dextroposition. It is not dextrocardia, it is called dextroposition. But if you see the whole mirror image of this, that is called a true dextrocardia, which is associated with situs inversus totalis. When you hold the apex and rotate the heart so that the apex comes on this side, so it will lead to dextroversion. So in this particular case, what happens? That the apex is on the right. In this dextroversion also the apex is on the right, but here it is a mirror image. So you can see this is mirror image. The right ventricle is anterior and left ventricle is posterior. But in this particular case, because there is a rotation, there is no situs inversus totalis. The left ventricle will become anterior and the right ventricle will become posterior. And in dextroposition, you will have the same normal type heart, but the heart has just slide. It could be an embryologically slide heart, or it could be because of some pathology in the lungs. So how are we going to image in patients with dextrocardia? The subcostal view is going to be the same like the normal view, but what we are going to see that the apex will be facing towards the left, or towards the right instead of left. The subcostal view, the position will be the same. In case of four-chamber view, the apical four-chamber view, that will be the mirror image. Like, because the true dextrocardia is a mirror image of the normal heart, the position of the probe will also be the mirror image. So the four-chamber view, you put the probe, normal condition, you put the probe over here. So mirror image probe will be on this side. So it will give you a four-chamber view. Now this is the heart is positioned in this way. So the long axis of the heart is like this. So this will be the position of the probe. In case of normal heart, the position of the probe will be like this. And in this case, it will be exactly the mirror image. It will give a long axis view. For short axis view, you need to put the probe exactly the mirror image of what we do. The aortic short axis view, you put the probe above the nipple at this point, and in this true dextrocardia, you will put the probe exactly like this. No, we should not use right-left cursor. If you use right-left cursor to get the similar image what you get in the normal heart, then you will not be able to put the probe in a proper position. Now coming for the dextro position, the heart is the same as the normal heart, but instead of heart in this position, the whole heart is in this position. So the subcostal view is going to be the same. The apical portion, the apical view is just shifted from this point to this point. Because the long axis of the heart is the same, so the long axis, instead of putting the probe here, you just slide the probe little bit on this side, it will give you the long axis view. And the short axis view, instead of getting short axis view over here, you slide the probe in this, so this will give you the long axis view. This position in a true dextrocardia will give you the long axis view, but in case of dextro position, this position of the probe will give you the short axis view. So this comes with practice. You have to keep on practicing it so that you can get the proper image. Thank you so much. I know that little bit more confusing, and this confusion will go with more practice. Thank you so much. And I would like to invite the questions from the audience.
Thank you very much, sir, for this wonderful presentation. You really explained it in very lucid way. Thank you so much. Let me see the questions if we have in chat box. Participants, I would request you to post your questions, or you can unmute yourself and ask. So far, there is no question, sir.
Dr. Shahid.
Dr. Pratik Singh is asking, like, if possible, if I can share Dr. Ritesh's number, your phone number.
Yeah, no problem. I can share my slides. Can I share my slides on this platform?
Yes, please, sir.
Is it possible to share?
Yeah, you just stop sharing the screen. You already stopped, no? Then you can.
Yes. Is it possible to share the slides on this page? Like, I'm ready to share. Everybody, like.
Yes, definitely, sir. Please share.
So how to share? You have to guide me.
Sir, good evening, Bhaskar here, sir. I think better you can send it to seminar, sir. Then we will send it to particular those who have requested.
Okay, no problem. No problem.
And there is compliments for you, sir. It is very helpful for beginners like us, sir.
Yeah.
Hi, Dr. Ritesh.
Yes.
I'm Dr. Shahid. Very nice to see you after a long time.
Seminar, we have Dr. Shahid with us. He's from Bangladesh.
Oh, sir. Pleasure to have you in this platform. Thank you very much, sir, for joining us.
So we did fellowship together when we were together at Narayana Rudalaya. So it was actually surprise package for me to have him on this platform.